All right, so when we're looking at the shoulder exam, we want to start with inspection. And the thing that you want to notice is symmetry. So is there any asymmetry in the shoulder from one side to the next? We always look from both the front and the back. You look at the contour of the deltoid, the AC joint, which in a female will often be right under the bra strap. It often helps to have someone situated in a tank top so you can see the shoulder exposed. You're going to, let's have you stand up and turn around this way. You're going to look in the infraspinatus fossa to notice whether there's any atrophy of the musculature. The supraspinatus fossa, which is here, is often covered by the trapezius, so that's not as easy to see, but the infraspinatus is a little bit easier to see on its own. Let's have you sit back down here. The next thing we'll do is palpation, and I typically will approach this starting from the sternoclavicular joint. You can work your way from medial to lateral and work your way all the way out to the AC joint. And simply pressing over the AC joint will often be helpful. If there's tenderness over the AC joint, that may indicate some form of pathology. You want to work your way around from the AC joint to the anterior part of the shoulder on the greater tuberosity. And this is where the supraspinatus inserts. And as you work your way back on the greater tuberosity, you'll note where the infraspinatus inserts. In the front of the shoulder here, you can't directly feel the biceps tendon, but you'll note where the biceps comes in the front of the shoulder. And they may be tender here if they have biceps pathology. Again, you want to note just the contour of the arm. You may notice where the pectoralis comes in here. And in certain cases, that may be important. For instance, if someone may have a pectoralis rupture. Next, we'll move into range of motion. The range of motion we'll look at in multiple planes. And I typically will look at this in at least 3, sometimes 4 planes. The first is forward flexion. And what you do is you move the patient's arm in forward flexion like so. External rotation with the arm at the side is performed like this. External rotation with the arm in 90 degrees of abduction is performed like this. And internal rotation can be performed either in this way or more commonly bringing the arm behind the back, and you'll use the vertebral level at which your patient's thumb reaches as the marker for how much internal rotation they have. Now, all of these maneuvers can be performed with the patient either seated or laying on the exam table. A natural progression from range of motion is to go into strength. And we will test the muscles of the upper extremity, most importantly the rotator cuff muscles, and we can move into other muscles such as the bicep, deltoid, trapezius, but we're going to start with the rotator cuff musculature. Now, it's important when you're testing the rotator cuff to note the plane of the scapula, and the plane of the scapula is approximately 30 degrees from the horizontal plane of the torso. So when I'm testing the supraspinatus, I would bring the patient out in abduction, but then forward approximately 30 degrees to test the supraspinatus. I'll have the patient point the thumb down towards the floor and then push up towards the ceiling to test the supraspinatus. To test the infraspinatus muscle, we'll bring the arm down to the side. We'll resist in this direction and have our patient externally rotate the arm against our resistance. To test the teres minor muscle, we bring the patient up in full abduction and external rotation, and again test this muscle against our resistance. There are multiple tests to test the subscapularis strength. The first test is called the belly press test, in which the patient places the hands on the stomach, and we ask the patient to bring their elbow out like this. A positive test would be when the patient cannot bring the elbow out to the side. In other words, the wrist remains flexed. That would indicate some weakness in the subscapularis. Another test to measure subscapularis strength is called the lift-off test. This test involves bringing your patient's hand behind the back and then lifting it off from the low back, such as this. You ask the patient to lift her hand away from her back. If she can do it, it's a negative test. If she's unable to, that's a positive test. This next test for the subscapularis is called the bear hug test, and we'll ask our patient to take the affected shoulder, in this case the left side, and to bring it across her body to hold the opposite shoulder. What we're going to do is attempt to lift the hand off of the shoulder, and she's going to attempt to hold her hand on her shoulder as tight as she can. If we're unable to lift her hand off the shoulder, that's a negative test. If I'm able to lift her hand off the shoulder, that's a positive test that demonstrates weakness in the subscapularis. So after the strength tests, we move into numerous special tests. One of the most common things we're testing around the shoulder is the rotator cuff, and there's multiple tests that can help us look for inflammation around the rotator cuff. One of the most common tests is called the near test, in which you have the patient hold the thumb pointing towards the ground, and we move the patient's arm through an arc of motion. A positive test would be where the patient has pain in what we call the impingement arc of motion. Another impingement test is called the Hawkins test, and the Hawkins test involves placing the shoulder, such as this, and internally rotating the shoulder. This maneuver will elicit pain in this general region if there is inflammation in the rotator cuff. Another test to look at biceps tendon pathology is called the Speeds test. The Speeds test, we ask our patient to place the palm up facing towards the ceiling. We place our palm on the patient's wrist, and she's then instructed to resist and elevate her hand up towards the ceiling. A positive test would elicit pain in the biceps tendon and often radiate into the biceps muscle itself. A natural transition from the Speeds test is the O'Brien's test. The O'Brien's test is looking at superior labral pathology, such as a slap tear. The way to do that test is to bring the patient's arm out in full forward flexion, to bring it across her body at approximately 15 degrees, have the patient point the thumb down towards the floor, and then again push up towards the ceiling and you give some resistance. Pain deep in the shoulder with that test is indicative of labral pathology. Tests that are specific towards the acromioclavicular joint or AC joint are the cross-body adduction test. That test is performed by placing the thumb directly over the top of the AC joint and bringing the patient's arm across the body, such as this. This test loads the AC joint. If the patient has pain in the joint when you perform that test, then that indicates a positive test. Now, of note, you should note that the O'Brien's test can load the AC joint as well, so sometimes you will get a positive test when you're doing the O'Brien's test, and it's important for you to distinguish where that pain is to determine which of those different areas is actually leading to the positive test. The labral shear test is another test that will look for labral pathology. I find this test easy to perform with the patient laying supine. The reason for that is it stabilizes the shoulder blade. What you do is have the patient relax as much as possible and have them bring the arm out in abduction and external rotation. And then you slowly take them through a range of motion, bringing the arm above shoulder level. And if there is superior labral pathology, they will often have pain in this region. Sometimes you'll be able to elicit a click or a pop in this general region. Another test that you can easily transition into is the apprehension test when you have the patient in this position. Again, you bring the patient into full abduction and external rotation. and bring the arm out like this. If the patient feels apprehensive, as if the shoulder is going to come out, that is a positive test. By placing firm posterior pressure on the front of the shoulder, if the patient feels that their symptoms get better and they feel more stable or less apprehensive, that is the relocation test. That would be a positive relocation test. So move directly from the apprehension test to the relocation test. With the shoulder exam, it's important to be thorough, and it's important to match your exam with the patient's complaints. I hope that you found this helpful and that you will use this instruction to become a better shoulder examiner.